Hi, I'm Dr. Jared Gardner, and I am here today with the awesome residents at University of New Mexico and fellows as well, I think, as well as some faculty. And we're going to go over some unknown cases. And these cases, you may notice, are titled VCU and UNM, and that's because I used them for a similar session with the VCU residents back last fall, and unfortunately had a technical issue that corrupted the whole recording. So I'm reusing them, but I apologize, VCU, that we didn't get a chance to put your session out there. So this will hopefully make up for it. Okay, so we are on case 1 here. Does anyone want to volunteer to tell me what you guys think about this case? A 65-year-old man with a large ulcerated subungual thumb nodule, and this is an amputation specimen. Let me maximize it here. So here's view number 1.
I can go like this.
Okay.
So we're looking at an amputation specimen, and you see a large tumor extending very, very deep throughout the tumor. And if you zoom in closely, it looks like it's forming nests.
Oh, good, yes.
Lots of mitoses throughout.
And there's one right there, actually. Good.
Yeah. So I was looking for any epidermal involvement, things like an overlying melanoma in situ, and wasn't able to find any.
Here, and before I move to the next one, just to show, this is articular cartilage from the phalanx bone, and then this is the bone. You can see the tumor is coming from up here. Like you said, the epidermis is kind of ulcerated and gone extensively. I think this was under the nail, actually, and it's grown way down and penetrated all the way through. This is where cortex of bone used to be. I know in derm, you guys don't see bone very often, but that's where the bone used to be, and this is tumor growing into it. And you're right that most of it does not have epidermal involvement. If I look around very carefully, I found some areas where I wonder about it, but I think that's all junk and debris. Let's look at the next slide. Here's another one, and I love this view because look at those. Swoon. Oh, how can you, if you don't like that, I can't help you. I mean, man. Pacinian delight. It's all the Pacinian corpuscles you could ever want. It's like my favorite normal structure microscopically. Okay, but anyway, sorry, back to the case at hand. So here's tumor, and you're right, this is a problem that happens sometimes, that the epidermis gets effaced or ulcerated, and we can't evaluate whether there's any in situ there or not. So what do you think, though, most likely that this is, or what's your differential, and what would you do to solve it?
So I'd be concerned for melanoma with, atypical, lots of mitoses, these nest-like structures.
Good.
So I'd definitely be interested in throwing some melanoma markers at it.
Yeah, very good. And let's see, I think I've got another slide. I can't remember. I think there was one area where there is very subtle in situ, just a few cells, but most of the in situ is gone. But this is melanoma. You're correct. And melanomas, oh yeah, here. It's a very, very rare, tiny area of in situ. So this happens sometimes where we get a nodule, a big, rapidly growing nodule melanoma that ulcerates the surface of the skin and obliterates any pre-existing in situ that was there. And that always makes us worry, could it be a metastasis? So then you have to kind of put the clinical scenario in mind. If it's a single lesion, no history, different doctors have different views about how far you should go in working those patients up. Here on the thumb, I mean, almost certainly this is going to be a primary melanoma, and in this case it was. And so yes, melanoma markers were positive. SOX10 and MARC1 were positive here. And so it's a really dramatic example because we don't often see amputations for melanoma. Sometimes when they're fungating like this, it has to be done. One of the potential downsides from what melanoma surgeons that I've known have told me is that potentially these tumors, even though you clear the whole tumor, they can pop up with satellite lesions at the amputation stump, which can become fungated and ulcerated and problematic. So in a case like this, it probably doesn't matter because you've already got a fungating ulcerated tumor. So in any case, we don't see that very often. But subungual melanoma, as you guys know, is rare, but is certainly out there and is a real issue, and we need to be aware of it. And when I see melanomas in darkly pigmented patients, dark skin types, it's usually subungual or other acral melanoma. Only rarely have I seen melanoma in dark skin patients that are not acral. And look, we've got also, here's a nerve, and we've got perineurial invasion by the melanoma. And we've got deep involvement into the bone even. And, oh, there actually is another normal structure I was going to show you here. Look at that once it comes into focus. Does anyone know what that is? This is a normal glomus apparatus, a canal of Suquet-Hoyer. I'm sure I'm butchering the French name, but in any case, that is a little arteriovenous anastomosis from which glomus tumors are recapitulating those cells, and you see them most often in the digits. So an acral melanoma with bone invasion. And I like that you picked up on the nesting. Sometimes it's hard to see because you'll get like sheet-like areas, but even here you can kind of appreciate that there's small nests with kind of grayish to pinkish kind of or pale cytoplasm. And to me, nesting with that kind of cytoplasm, and especially if you get big, huge nucleoli like we see here, that right away rings the melanoma bell. But you could also consider other things. Poorly differentiated squamous cell carcinoma could potentially look like this. Other poorly differentiated carcinomas like metastasis, although metastasis to the hands and feet is rare. I've seen rare things that have done that, but pretty rare. And then you could also think of things like epithelioid angiosarcoma, other stuff. So those could be, if you're here, I would just do melanoma stains to prove it if I couldn't find the in situ, and then I'd be done and I'd sign it out. If the melanoma stains were negative, then I might expand into, ERG or CD31 for angiosarcoma, high molecular weight keratin or P40 for squamous cell carcinoma and beyond, depending on the situation. But a good example of the melanoma pattern there in cytology, and again, the nesting, good pickup on the nests. Even down here in the bone, the melanocytes like to make nests. For some reason, they just like to grow in that nested kind of clumped pattern, and that can be a really huge clue for us to make the diagnosis. So well done. Any questions? Okay, we'll move on to the next case. Case 2. And I'll load up the next one here. Okay, case 2 is a 40-year-old woman with a mass in the axilla. Oh, here, maybe I have to refresh it. There we go. 40-year-old woman with a mass in the axilla. And it's a huge slab of tissue here that we're dealing with, or multiple slabs. So these are huge, almost inclusion-like structures, and these are actually massive nucleoli in these tumor cells. And we've got large eosinophilic cells with abundant cytoplasm here. Let's look at some other areas. It's got a lot of different patterns to see. Over here, it's kind of like solid sheet-like growth. Does anyone know what cytologic feature that what we would call these cells? These cells that have eccentric nuclei and a bunch of eosinophilic cytoplasm kind of forming a pink blob here that pushes the nucleus to the side?
I would call those rhabdoid.
Very good. Yes, those are rhabdoid cells. And a rhabdoid cell is not a specific cell type. It's a cytologic pattern that can be seen in a variety of different things. And to my eye, rhabdoid and plasmacytoid are kind of closely similar things. Some people define rhabdoid to be strictly when it has like the pink globule. Some of these don't really have that. But in any case, I feel like they are very much overlapping plasmacytoid cells and rhabdoid cells. Look at the pleomorphism, just wild atypia in this tumor. Okay, so what kind of tumor might this be, or what kind of stains would you do here? Here's those big eosinophilic rhabdoid cells here, huge, massive ones. There, that's the kind of eosinophilic globule. See how it's making a big ball of pink? So usually that ball, it corresponds to a tangle of some sort of intermediate filament that's clumped up there and that's bulged up next to and pushing the nucleus to the side.
So I would get an INI1.
Great idea. INI1 can be lost, and it can be lost in a growing list of different tumors. So the main one that I think of is epithelioid sarcoma, but there's another tumor called rhabdoid tumor. That is, there's several types. There's rhabdoid tumor of the brain. There's a renal one. In the brain, it's called atypical teratoid rhabdoid tumor. There's one in the kidney. And then there's extrarenal rhabdoid tumors. And they show overlap with a form of epithelioid sarcoma called proximal type, a really ugly, cytologically ugly, highly malignant looking and very rhabdoid looking tumor type. And those are going to usually express keratin and EMA and have loss of nuclear INI1 expression. So that's one thing we can think of is rhabdoid tumor or epithelioid sarcoma. And then look here at this. We can see here that there's these small blue cells. These are actually lymphocytes. So whenever we have a nodule in the soft tissue that's in a lymph node rich region, like the axilla or the groin, you always have to ask yourself the question, could this be a tumor replacing a lymph node and therefore a metastasis? And in fact, that's what the scenario is here. This is a lymph node that's almost completely replaced by tumor and has rhabdoid cytology. INI1 is retained here. Keratin is negative. You could also think of rhabdomyosarcoma. Some of them have rhabdoid-looking cells, particularly like the epithelioid type of rhabdomyosarcoma. Very rare to see in the skin, but you can sometimes see it in the skin and also the soft tissue. And those are going to be, they're going to have retained INI1. They won't have loss of INI1, true rhabdomyosarcomas, and they'll have expression of desmin and also myogenin and myod1, which are nuclear markers of skeletal muscle differentiation. So those were negative here. This was positive for SOX10 and S100 and MART1. So this actually is metastatic melanoma. Totally different cytologically than in that last case of melanoma that we looked at in the acral subungual region. So it highlights just the incredible morphological diversity that melanoma can have cytologically. And just here in this one lymph node, you can see, these all sorts of different patterns in one lymph node. And so it gives you an idea of the range. So anytime we have a malignant epithelioid appearing or spindle cell tumor, I always am keeping melanoma in mind because it can really overlap with a lot of different things. And in fact, when I see rhabdoid or plasmacytoid cells in a malignancy, melanoma is actually the top of my list because melanoma is much more common than, rhabdoid tumor and epithelioid sarcoma, etc. So I feel like the most common rhabdoid looking or plasmacytoid looking malignancy that I see is actually melanoma. And the books kind of describe rhabdoid melanoma as being rare. I feel like I see rhabdoid cells in melanoma relatively often, and usually it's either in big, bulky primary melanomas, like large nodular ones, or like this, in large metastatic lesions, like in the lymph node or in a distant met. I don't know if that's 100% true, but just in my experience, having seen, I don't know, well over 1,000 melanomas, probably several thousand by now, the rhabdoid cells that I see usually are in big, large melanomas that are very ugly nuclei, lots of mitotic activity, and large lesions. So always when you see these, this is a good lesson for seeing rhabdoid cytology and thinking about melanoma plus some of those other things. You could also include in your differential, again, maybe even epithelioid angiosarcoma. Probably not, but a possible poorly differentiated carcinoma of other sorts. So, you do need immunostains to guide you here, especially if the patient has no history. And I can't recall this patient's history. I believe they did have a melanoma primary on that arm years previously, and this was a large metastasis that develops. And, sometimes patients start with a very small primary. Sometimes that primary even regresses away totally, and you end up with a large, bulky metastasis, which kind of defies logic. It doesn't seem like right that a tiny little melanoma can give rise, but it's because I think once the tumor spreads, those cells that have whatever genes have changed to allow the cells to spread and live and grow on their own allows that subset of the tumor to be a really aggressive, growing active nodule. And also it's not confined by the boundaries of, the dermis. It's here in a lymph node where it's got lots of space to expand and grow. So a really good example here of rhabdoid cytology and a rhabdoid metastatic melanoma. Okay, great. Now, let's do the next case.
Can I ask a question?
Oh, yes, yeah, let's go back to that. Sorry, I'll pull it back up. Okay, go ahead.
Yeah. How do you handle the melanoma markers in your practice?
Okay, so how do I do melanoma markers in my practice? That is a great question, and it depends on the scenario. When I'm looking at a regular skin lesion and I'm trying to decide, is this a dysplastic nevus or a melanoma, I often use markers like SOX10, or some people like MART1 better, to look for the growth pattern to see if there's pagetoid spread or confluence. And then in my practice now, I often use PRAME. It's not a perfect marker, but it's pretty helpful. And then in spitzoid things, I do other stuff as well. And then when I'm in the context of looking at, is this chunk of tumor in a lymph node or somewhere else, is it metastatic melanoma versus other? In this setting, what I want is a very sensitive marker to rule out melanoma. So usually I would start with SOX10 or S100. In my hands, they're both relatively the same as far as sensitivity goes. I feel like SOX10 is a cleaner stain, and it is not S100 stains quite a few different things, plus background Langerhans cells and dendritic cells. SOX10 does stain other things like neural lesions. It can stain poorly differentiated metaplastic breast cancer and others. So it's not a totally specific marker for melanoma, but it's very sensitive and it's very clean. So I usually will start with that. You can start with MART, and if MART's positive on this, you're done. Is metastatic melanoma. There are some very rare other things like clear cell sarcoma or something that you could think about, or malignant PCOMA, but depending on the morphology and the situation, you may or may not consider those things. Here, I think is way too pleomorphic to fit for a clear cell sarcoma usually. They're not usually so pleomorphic. But I usually, though, would do SOX. If SOX is positive, then you can add MART to help confirm it. But I see melanomas that have total loss of MART and HMB on a regular basis, particularly spindle cell melanomas and almost essentially always desmoplastic melanomas. And then also big, bulky melanoma mets like this often begin to de-differentiate and lose their melanocytic marker expression, either partially or completely. So, a big ugly epithelioid melanoma usually will have some MART left in it somewhere, but it can have big zones of loss. So like on a core needle biopsy, MART can be totally negative, and especially in spindled melanoma, I see that all the time. And then people are, always like thinking it's going to be a neural tumor or something like that. And usually it's just a spindle melanoma. So it's kind of complicated, but that's basically my kind of basic approach. And I actually have a video about melanocytic immunostains. It doesn't include how I approach PRAME, but it kind of goes through SOX, S100, HMB, and MART, and talks about how I use them and in what situations I use them or don't use them. And I've got like a little table in that video that I show. It's a table from my Dermpath Survival Guide book, but you can check that out. It's on YouTube and Kiko. Just look up like melanocytic immunohistochemistry, and it should pop right up. And that has a more detailed table than what I just mentioned. So, any other questions?
What are your thoughts on PRAM and its incorporation into your staining melanomas?
So I use PRAME in the setting of a primary like skin lesion where I'm trying to decide, I know it's melanocytic, and I'm trying to decide if it's an atypical nevus or a melanoma. PRAME can be helpful there, that if it's strongly positive or positive in the majority of cells, it can either tip me over the edge from calling something atypical proliferation, I'm not sure, to calling it just outright melanoma, or it can at least raise enough concern that I share it with my colleagues or maybe do molecular testing. It depends on the situation. If it's negative, it's reassuring, but there are melanomas that are sometimes PRAME negative. So it's not a perfect stain, but it's pretty helpful in select situations. I don't do it on everything. I personally don't ever use it on metastatic lesions, because here I know this is malignant. All I'm trying to figure out now is this tumor melanocytic differentiation, or is it carcinoma or something else, right? I can see by the cytology, the mitoses, and the fact that it's replacing a lymph node that we're dealing with cancer here. So PRAME, I think, is helpful for trying to help us decide cancer versus not cancer in melanocytic lesions. Here, the cancer question's answer. The question now I have is it melanocytic versus other type of cancer? So that I wouldn't use PRAME in this setting, but I do find it helpful in skin biopsies. Anything else before we move on?
Sorry, have you found PRAME helpful in skin excisions for melanoma where you're trying to decide if there's residual versus melanocytic hyperplasia?
No, not really. Oh, the question, I'm sorry, I need to repeat these for online. The question is, in skin excisions, do I find PRAME helpful if I'm trying to decide is there some focal residual melanoma, like melanoma in situ, versus background hyperplasia, like maybe like you'd see in an excision of lentigo maligna on sun-damaged skin? I don't, because I feel like you can see some scattered PRAME in the background skin. Particularly, I've heard from other dermpaths who I respect who have said that in sun-damaged skin, especially, some of those single-cell hyperplasia can have some PRAME positivity. So I personally feel like it can potentially cause excess angst, maybe. And then like, what do you do if you find one PRAME positive cell at the margin? Do you call it positive? Do you not? I don't know. I don't know if there's a known answer to that yet. It also may be for the fact that for 8 years of my practice, I did not have access to PRAME regularly. And so I got used to evaluating those kinds of margins just based on H&E. Plus, if I needed, sometimes I'd use SOX or MART1. So it may be different if I would have used that from day one. But I personally don't. And also the other thing is, on a skin excision, I'm not really worried if there's focal residual melanoma in situ versus hyperplasia. I just pick one and move on unless margins are involved, right? Because otherwise, deciding if there's a few little cells of residual melanoma in situ next to a biopsy site when a patient already has a known invasive melanoma it matters 0% for patient care, right? The only thing that matters is there invasion? If we had an in situ, is there invasion on the excision? Or if we had an invasive melanoma, is there deeper invasion or more atypical features or high-risk features like nerve invasion? Are there more, something worse prognostically on the excision than that was present on the biopsy? And then also, are the margins negative? And if I can answer those questions, then I'm not too worried about, I see sometimes people do multiple stains on excisions where the margins are obviously clear. And I personally, I just don't feel any need to do that because I don't feel like it adds any value to patient care. So that's my approach. And I'm sure others may differ, but that's how I approach it. Great.
For the search path folks out there, we also use PRAME on lymph nodes when we're trying to decide or just add support to, is it a subcapsular nevus versus metastatic melanoma.
So I pondered whether to bring that up, is if you're looking in a lymph node and trying to decide, is this capsular nevus versus metastatic melanoma, that PRAME could potentially be helpful there. And other people have advocated for using like HMB45 in that setting, which is going to often be negative in a capsular nevus and have patchy positive in a melanoma. I would say that with practice, most cases of a capsular nevus versus melanoma can usually be resolved on H&E most of the time based on the way the cells look and how they're arranged. If they're completely bland cells embedded in a linear fashion in the collagen of the capsule, then that, to me, that's got to be a nevus. Problems do arise that sometimes you get cells that are sitting what look like in the parenchyma and you can't tell, are they really in the parenchyma or do they connect to a little septum that's stretching down from the capsule? So, and I've seen some bulky like nodal nevi that look kind of scary. And so in those settings, for sure, there are certainly times where I've stained them and my colleagues have stained them as well. And yeah, I think PRAME could potentially help you out if you're struggling with a case like that. Great questions. You guys are an awesome audience. I might be with you till 1 o'clock, but or whatever it is, an hour late on your time. But hey, I am totally fine with that. I just don't want to make you guys late for clinic or anything. All right. Any other questions about this or about melanocytic stuff before we move on? So I could talk about this stuff all day. Okay. Hearing silence, we shall move on. And you can always tweet at me if you got a question later that's keeping you up at night, okay? All right, now we got case 3, and this is a 50-year-old man with multiple linear papules on the right shoulder and arm for many years. Man, if only every case came with that kind of very detailed history. I love it. And I can't remember what history this actually came with, but I know what the actual history is after subsequently finding out, and so I've made it more detailed for teaching purposes. Okay, any takers on this really fascinating case?
So this looks like a broad either excision of some sort. And then we can see already from here that in the dermis there's embedded this like almost basaloid kind of appearing group of cells that may be forming some follicular kind of structures there. There is some like parallels of keratin there as well. Almost remind me some of them to either trichofolliculomas or some a type of adnexal tumor with follicular differentiation. Because it's very broad, it was also reminding me maybe, and it says like in the clinical description it's linear, maybe some hamartoma of some sort. Or maybe there is I don't know, like a hair follicle nevus, or maybe follicular sebaceous hamartoma, even though I don't see many sebaceous glands, but it just reminds me about like this kind of trichofolliculoma kind of differentiation, but it's like very broad.
Excellent. I love that description of these multiple nodules. We do have an excision. I think this was taken out by a surgeon. One clue is we can see this is cautery effect on the collagen. So you often see cautery in the epidermis and get quizzed about that, I think, where the nuclei of the epithelial cells stretch out and get elongated. But it's also important to recognize cautery in the collagen. You get these burned, destroyed edges, and then the collagen next to it is like blurred and smudgy, compared to, the nice crisp pink normal collagen. So most of the dermatologists that I have worked with do not use cautery regularly to remove, or cautery / electrosurgery, Bovie, whatever name you want, electrical current to cut. They may cauterize things after they've removed something, but I don't usually see any of this cautery or electrical current effect in things removed by dermatologists. So I do cheat a little bit, but when I see this, I know a surgeon probably removed this, or a non-dermatologist probably removed it, okay? So the other thing is that I love that you described that we've got basaloid nodules, multiple little circumscribed nodules that are basaloid. They have appearance that gives you the feeling of a hamartomatous process and potentially something that has follicular differentiation, because you can see that there are these kind of cords that are like pink keratinocytes with little keratin horn cysts, or almost like little pearls or horn cysts here, mostly of orthokeratin. And then you also see little blue basaloid buds, particularly out here along the periphery, that reminds you of the germinative hair root of a hair follicle. And so all those things together call to mind a benign follicular thing. So if we put all of those together, we come up with the name. This is a basaloid follicular hamartoma. And this is a great case because this patient had this very unique presentation of multiple papules in one region of the body that were in a kind of linear Blaschkoid sort of fashion, and growth in a linear arrangement along Blaschko's lines. And so this is one presentation that you can see. Basaloid follicular hamartoma comes in multiple different flavors, so to speak. One of those is that you just see them as solitary lesions. The other time you can see them there's familial syndromic forms, and then there's acquired forms. And one of the forms that I believe is thought to be acquired is this form, linear multiple basaloid follicular hamartoma. And this case stands out to me in my mind as the gold standard of what a basaloid follicular hamartoma looks like, because the patient had this very unique presentation that fits well with this and not, say, basal cell carcinoma. And also, this patient, it turns out, had a previous biopsy of one of these lesions like 10 years before that was also called basaloid follicular hamartoma, and never ended up having progressive growth or destructive, just locally destructive aggressive growth like you would expect the basal cell that's neglected for a long time to do. So that is nice. And so sometimes we see these as little tiny foci incidentally around hair follicles in normal skin, and I don't even usually mention them. Sometimes you get these biopsied, and when they're a solitary lesion in an older sun-damaged person, you can really begin to wonder, should I call it basaloid follicular hamartoma, or do I call it basal cell carcinoma, the infundibulocystic type, or basically basal cell carcinoma with follicular differentiation? And there's lots of controversy and debate over that, and over whether or not this represents a benign process or if it represents a form of basal cell carcinoma when it's solitary. When we have it here in this kind of linear arrangement, I think it's pretty clear that this is a benign hamartoma. But when you see single lesions like this, sometimes people will call them basal cell infundibulocystic type. So there's, just like everything in dermpath, there's lots of debate among different experts, and particularly I think when you get into adnexal, and hair follicle tumors, you get lots of different strong opinions about these things, okay? So this one I like because I actually know, based on the clinical, that this is behaving in a benign fashion and is presenting as a benign hamartoma. So that's the features all nicely laid out here. And another thing I had from a case that I saw as a solitary lesion, I'll show you, it was a solitary pedunculated lesion. And I think you can tell it looks very, very similar to that case I just showed you. So here we have the same kind of pattern as we had previously. And in this case, I actually did, it's a slightly more stranded looking. There's also a little bit of keratin-derived amyloid, which you can see in basal cell carcinomas and a variety of adnexal tumors, and seborrheic keratoses, etc. There's little clumps of keratin that get together and make pink smudgy stuff that have cracks in between. And then look what I did here. I did a cytokeratin 20 immunostain. So these are Merkel cells, benign Merkel cells that are just hanging out. They're like on the train for the ride, just along for the ride, colonizing this process. In general, my kind of thinking is that when you have a basaloid neoplasm and you're debating between benign hair follicle tumor versus basal cell carcinoma, when you have abundant scattered benign Merkel cells that are in the lesion, highlighted by CK20, that favors a benign follicular process rather than a basal cell carcinoma. Now, There's plenty of debate about that, and there have been tumors that people have described that are obviously invasive or more aggressive that can have some Merkel cells in them. So it's, just like everything, nothing is a perfect solution to the problems that we face in pathology. But I find this very reassuring and helpful when I think something is a benign follicular tumor, and then I do CK20 and there's multiple scattered Merkel cells in it. To me, that's a reassuring point to favor Basiloid follicular hamartoma or trichoepithelioma or trichoblastoma. Doesn't seem to work for tricholemomas, I think, because it's made of a different part of the hair follicle. But in any case, you can go and do more reading about this because, again, like I said, there's controversy here, but this is my approach. So this lesion right here, I call this Basiloid follicular hamartoma benign. All right? And to me, it looks very, very similar to that last case that we saw, the one that was linear and multiple. But I think some people might call this a infundibulous cystic basal cell, and I can understand that there might be different approaches. So that's just my approach. Let's see. I go back to the... Okay, so that's it. Basiloid follicular hamartoma, the linear multiple form of it. Any questions? Chat. Would you rely on BRAF or BCL2 to favor basal? So no, I wouldn't, because I feel like, so BRAF will stain both follicular neoplasms, like, well, at least trichoeps and trichoblastomas, and I believe it would be positive here, as well as basal cell. It's a relatively non-specific stain. I find it helpful sometimes to help me between basal cell carcinoma and AK, like a little superficial basal, sometimes can mimic actinic keratosis. BRAF can help there. I find it helpful if I've got an ugly basaloid tumor, and I think it's just an ugly basal, but I want to make sure it's not a squame. If BRAF has got a lot of staining there, that would be a point to support basal. Although, again, it's a pretty non-specific stain. You can get some staining in squame or other things sometimes. But in hair follicle tumors, although some people have described some differences in the pattern of BCL2 and BRAF, I feel like it's, to me, too subtle to be able to confidently sort out. So most of the time in all of the hair follicle versus basal cell, I usually just use H&E. Sometimes I supplement it with CK20. There have been studies about a stain called FLADA1, or that's how I pronounce it, PHLDA1, which will stain benign follicular things like trichoep and be negative in basal cells, I believe. Let me double check to make sure. I always get that confused because I don't actually use it in my practice. I've never had a lab that had access to it regularly. So, pause. Yes, the trichoeps are positive and basal cells are negative, at least in some small studies that have been done. So it sounds like a good marker, but I've not actually had a chance to use it yet. But I find that a lot of those other markers like BRAF and BCL2 are too, to me, pattern reliant. And I feel like pattern things where I have to say, well, it's more at the edges than in the center. To me, I find it really hard to use those to really nail down a diagnosis any better than I would do on H&E. So I don't personally, but I'm sure there are some other people that use them and find them very helpful. Okay, we'll move on to the next case here. Okay, so case 4 is a 20-year-old woman with a slowly growing, quote, cyst, unquote, on the buttock for 5 years. And anyone who's watched any of my YouTube videos know that I love to just completely, constantly make fun of the cyst thing. Not because I'm trying to be mean, but because lots and lots of things I see get misdiagnosed clinically as cyst. Because any sort of nodule in the dermis or subcutis is going to look like a skin-colored lump or bump on the skin, and because cysts are super common, people are going to think it's probably just a cyst or a lipoma. And I've got a whole box of things that are not a cyst and not a lipoma and ended up being all sorts of different sarcomas and adnexal tumors. So that's why I encourage people to not just blow everything off as a cyst. I know in dermatology you guys are more familiar with that, but especially in primary care, I want to make sure people are aware of all the things that are supposed to be cysts that end up not being. Let's see if I can fix. There we go. Well, we've got a little watermark, but that'll be fine. Okay, so anyone want to take this this case here?
I'll take a stab at it.
Okay.
All right, so as you mentioned, this does not look cystic here, so we have a nodular proliferation. Fairly thin epidermis overlying it. It looks like in the nodule itself we have fibrotic areas, kind of that boreas mephilic look that you're pointing out. And then we have an edematous area in the middle, and then some more cellular areas kind of around the periphery. We do have some enlarged kind of open vessels throughout, especially in some of the less cellular areas. And then when we go to high power, I feel like most of the cellularity consists of bland spindle cells, but there are kind of giant cells, smudgy cells scattered throughout. And I was noticing particularly around a lot of these open spaces. Yeah, like this is a good one. I'm not sure that's strictly a vessel. I think those are giant cells around like a pseudovascular space.
So that is an excellent description of all of the features here that we have. Excellent work that we have collagenous zones, kind of myxoid or edematous zones, some more cellular areas at the periphery, and most of the cells are bland, kind of spindled cells. Some of them look a little more oval here, depends on kind of the cut. And then we have these smudgy hyperchromatic cells that look kind of pleomorphic at first, and it's a little hard on this scan to tell, but they actually are kind of multinucleated or multilobated, and then those cells tend to cluster around these open spaces that look at first glance like vessels, but as you astutely pointed out, are not actually real vessels. That's a real vessel here, this little one. This is a pseudovascular space that is lined by hyperchromatic multinucleated cells. CD34 would be diffusely positive here, and this tumor would be negative for STAT6, and negative for S100 and most other markers that you might try to stain it with. So does anyone know what this might be based on that immunophenotype? Let me show you some other areas around the edge to see.
Is it a giant cell fibroblastoma?
Very good. This is a giant cell fibroblastoma, which is basically a variant, a morphologic variant of dermatofibrosarcoma protuberans, of DFSP. And this is the type that's is really first described in kids as the pediatric variant of DFSP. Kids can get this variant, and they can also get regular conventional morphologic appearing DFSP. And we also know that adults can also get giant cell fibroblastoma. And when I've seen it in adults, almost always I've seen it like this, where it's got some conventional areas of DFSP, often with myxoid change at the periphery or somewhere else in the tumor. And sometimes you can get a DFSP that recurs and looks more like giant cell fibroblastoma, or a giant cell fibroblastoma that recurs and looks more like conventional DFSP. So they really are the same tumor, to my thinking and understanding, and they have the same molecular abnormality, which is a fusion of collagen 1A1 and PDGF-beta. And there is a new fusion described in a small subset of DFSP, which is a fusion of PDGF-D, D as in delta, with a variety of different fusion partners. I do not, to my knowledge, that has not yet been described in giant cell fibroblastoma, but these are much, much more rare than regular DFSP in my practice, at least. I've only seen a small handful of these, and I've seen quite a few conventional DFSP. So I suspect that eventually someone will describe a PDGF-D variant in one of these giant cell fibroblastoma versions. So when I sign these out, I call it dermatofibrosarcoma protuberans, giant cell fibroblastoma type, and just explain that it's a morphologic variant. It's more common in kids. It basically needs the same treatment as regular DFSP. Last time I checked, I was not aware of any of these that have metastasized, but we know that conventional DFSP very rarely metastasizes. It's more often the fibrosarcomatous, higher grade ones that do. So that's kind of my thinking. So the key here is loose myxoid stuff with bland spindle cells, scattered multinucleated hyperchromatic giant cells. And my understanding is on electron microscopy, these are actually not truly multinucleated. They're multilobated cells that all connect up. But to my eye, they look kind of multinucleated. And they tend to, this is the most really nice classic example. They don't always do this, but they classically will have pseudovascular spaces around which those multinucleated hyperchromatic cells line up. So I always like to teach that translocation-associated sarcomas or other translocation-associated tumors with a balanced gene fusion, usually do not have pleomorphism. They have uniform monotonous nuclei. But I would say that this is kind of an exception to that rule. This is one of the small list of those tumors that does sometimes have cells that look more hyperchromatic and pleomorphic and a little different from the other cells, okay? So they tend to cluster around here, and because of this, you could even, if you're having a bad day, think, well, they're atypical, they're lining a vascular space, maybe it's angiosarcoma. I mean, if you've seen some angiosarcomas, you should be able to tell this is not. But I could see that if you had a small biopsy of an area just like this, it might make someone worry about that. And CD34 is positive, which also stains some angiosarcomas, also some are negative, which is one of the many reasons I don't love CD34 as a vascular marker. I like CD31 and ERG much better. I've got a little write-up about that on Kiko explaining how I use vascular markers. That's a story for a different day. And then I also find it helpful to look around for the areas that look more like regular DFSP. Here we're kind of limited by the fact that we don't see fat entrapment, right? We're not seeing really much in the way of the honeycomb pattern of fat entrapment. Oh, there might be, oh wait, I forgot, down here there is. Very subtle. Oh, sneaky look. Now that looks like classic DFSP. I even forgot it was down there because it's so easy to focus on the middle. So that's the other take-home lesson here. It's been a while since I looked at this slide. Always remember to check around the edges and I actually try to do that when I first look at a biopsy and I see a big tumor in the middle. I try to check around the edges and look at the skin adjacent so I don't miss a subtle clue, because otherwise I'm going to hone right in on that big ball of tumor in the middle and get fixated on looking at it. And sometimes it will have all the answers, but other times there will be clues that will make my job a lot easier around the periphery, like this obvious DFSP way out here. That's got the nice storiform, swirling, bland spindle cells and some entrapment of fat. Okay, so this is a hybrid of conventional DFSP and giant cell fibroblastoma. And the last point I'll make before moving on is that in adults sometimes you see, or I guess kids too, but you'll see myxoid variant of DFSP. Myxoid DFSPs have overlapping features with giant cell fibroblastoma. So to me, the way I think of it is the more myxoid a DFSP begins to look, it gets more hypocellular. It will start to sometimes get some of these, usually rare, but multinucleated cells, and also it will get cells like this. See how these cells are kind of triangle shaped or pointy at the edges? So people call those stellate cells. Stellate to me means like star shaped. I want a 5-pointed perfect star. I'm a very concrete thinker. That's what my psychiatrist wife says. But to me, so stellate cells to me are more like triangle shaped cells. Some of the visual analogies in pathology don't really work with my brain. But in any case, when you see a myxoid spindle cell tumor that has some stellate cells and you begin to see some cells with maybe 2 or 3 nuclei, do a CD34 and maybe even consider FISH, because sometimes myxoid DFSPs can lose expression of CD34, just like the higher grade fibrosarcomatous ones can. So a myxoid DFSP, though, can be very treacherous because it can be pretty bland and myxoid and not very cellular, and it doesn't always have obvious fat trapping or a storiform pattern. But I do find it helpful. The stellate triangle cells and multinucleated cells make me think of myxoid DFSP because it begins to kind of take on some of the characteristics of giant cell fibroblastoma. Okay, excellent job, guys. So this is a really good example to learn giant cell fibroblastoma variant of DFSP. Any questions? Okay, this is case 5, a 60-year-old man with a solitary verrucous lesion on the lower leg, and this was courtesy of my friend Dr. Travis Vandergriff in Texas. And let me get the next one queued up here to load, just to make sure my computer caches it. Okay. All right. Anyone have some takers for what this might be?
I can try this one. So we have this sort of like lattice work of these really thin, sort of, blue epidermal strands connecting to the epidermis. And then I think sort of within the strands there are a few little ducts, and there's this fibrovascular stroma around. So with the history, I was thinking an equine Cyringo Fibroadenoma.
Excellent job. Nailed it. Yeah, I think that this is a pretty good example of equine Cyringo Fibroadenoma, which people debate. There's multiple different forms. It can either be solitary lesion on a wide range of sites and ages, but I kind of feel like the leg is one of the more classic sites, but it's been reported in many different areas. And then some of them can be multiple. There's a linear form that's been described I've never seen. I've only seen a couple of these in my practice. And there's times where you can see this pattern as a kind of reactive change. So there's some debate back and forth of are they reactive or neoplastic, or maybe there's a couple different things from different etiologies that have the same appearance. I think this one's a little bit hard because it doesn't have very many ducts. And you could, if you wanted to be a devil's advocate here, someone could make the argument that, well, this may just be a wart or a prurigo nodule that's very tangentially cut. And I think that's possible, but I still think it's just way too much expansion and elongation of the reedy. But normally, the normal teaching that I say is if you see islands of papillary dermis surrounded by epidermis, that means that the cut is tangential, oblique. The microtome is not slicing straight down at a 90-degree angle to the skin surface. It's going at an alternate angle that's more shallow than that. And because of that, you're seeing the reedy connecting instead of the normal, kind of finger or test tube shaped reedy that we see. And what you'll also see is look at the papillary dermis. So we do have some tangential section here, but I still think it's a Cyringo fibroadenoma. Here's the normal papillary dermis with its vessels, right? And there's a bit of stasis change here, right? But then as we go over here, you can see See this expanded zone here? Part of that is probably a reactive fibrosis to the tumor, or to the lesion, but also some of it may be that we're tangentially cutting through the dermis. So just so you're aware of that, there is some tangential sectioning at play here. But to me, elongated thin strands that connect together of keratinocytes with a variable amount of sweat ducts in the midst of them is Cyringo fibroadenoma or Equine Cyringo fibroadenoma. And if you like eponyms, it's a Mascaro. I used to say Mascaro, and then someone on YouTube just recently pointed out that Mascaro has an accent over the O, and he was Catalan, is Catalan, so that's his name has got the O accent at the end. So I was thankful to my colleague online who pointed that out to me. Thank you very much. And in any case, I think that this fits. At least it's the best example I have in my collection. And again, thanks to Dr. Vandergriff for donating it to me. So these are benign lesions, and I think it's just good to be aware of them because they have kind of a unique pattern. So normally interconnected reedy like this with windows of little or islands of papillary dermis, think of oblique or tangential sectioning, but a few lesions can produce that Cyringo fibroadenoma, Cyringo cystadenoma papilliferum, although it looks very obvious and different once you are familiar with it. And also one other lesion that we're about to talk about in a minute. But any questions about this first? Okay, let's move on to the next one. So this is case 6, and this is a 60-year-old man with an erythematous plaque on the lower back. And I unfortunately do not have a scan of this available yet, so we'll just have to do photos, but I'll scroll through them here. Similarities to the previous case of Cyringo fibroadenoma, which is why I'm showing them back to back to compare and contrast. And I apologize that these pictures are a little bit pixelated. They're from my older files, but hopefully they'll do. Okay, any ideas what this might be?
So with this one, I think this one had a little bit more peripheral palissading as compared to the previous, and maybe some retraction artifacts as well. So I was thinking of fibroepithelioma pincus, also taking into account the clinical history.
Very good. Yes. So this is a fibroepithelioma of pincus, which some people regard as a benign variant of trichoepithelioma/trichoblastoma, and other people regard as a variant of basal cell carcinoma. I believe the WHO currently classifies them as a form of basal cell carcinoma, but there have been plenty of debate about this in the literature. I told you guys previously, people love the debate about follicular things versus basal cell carcinoma, probably because there's no perfect right answer, and so you can just write endless papers about it and we'll never have a good proven answer. But I was always taught to regard them as basal cell carcinoma, but as I've read more about it, I think there's actually some pretty decent evidence that they at least are, maybe they're intermediate between a full-blown basal and a benign hair follicle tumor. If nothing else, we know that most of the data about these lesions shows that they have indolent behavior. And there have only been rare reports of aggressive behavior from these. And then you can debate whether that was actually transformation into full-blown malignancy or if it was actually this tumor itself. And if you're watching this online, there's a really nice review article about this tumor and about the pros and cons or the different aspects of what people think about it by Dr. Ellen Haddock and Dr. Philip Cohen, and it's a beautifully done review, and I'll put a link down below and I'll send it to you guys at UNM as well, so you can check it out, and then you can decide what you believe for yourself. So in any case, that's what I call it. So now the main thing though is how do we just sort this out from Cyringo fibroadenoma? Both of them have elongated thin strands or cords of keratinocytes that are pink. But and they connect together and they leave islands or windows. Fenestrae, right, is I think the Latin for window. So this is a fenestrated pattern that it has multiple window panes. If the dermis here is like panes of glass, and then these little cords are like the window frames, like in a, maybe or in like a stained glass window, if you like. And so I like that. I think that's quite a beautiful analogy. So you have that plus, like you pointed out beautifully, you have basaloid cells making these little buds and tufts that grow off of these strands, and they often get a little mucin and a little clefting around it, just like you'd see in a basal cell carcinoma. And there's a closer look at those. And I think at least some studies have actually used that marker FLATA1, the one that's going to be positive in follicular neoplasms, but negative in basals. So the FLATA1 PHLDA1 is the anastomosing strands are positive, but the little basaloid nubs here are negative. And negative staining is what you'd see in a basal cell carcinoma, and positive staining is what you'd see in a benign trichoep. So it kind of calls into question, and different people, I think, have taken that data and interpreted it differently. Does it represent a transition state into basal cell carcinoma? I don't know. In any case, you can read about it. I'll give you the link, and you can learn for yourself what you learn about it and decide for yourself. So when I see the basaloid basal cell carcinoma looking little buds, in addition to those strands, that's when I call it fibroepithelioma picus, because people ask me that question a lot. And there's that kind of myxoid mucin-rich stroma and the clefting around the edges that you often see focally. And these are classically most common on the trunk, particularly the lower back. Also, interestingly, on the sole of the foot. I've never seen one in that location, but it's been reported that when you don't see basal cell carcinoma very often on the sole of the foot, nor do you see hair follicle tumors there very often either. So I don't know exactly what that means, but I thought it's interesting that that is a described alternative site in addition to the lower back that I learned about when I was reading about it. So, all right, case 7 is a 75-year-old man, and this is from the nose, and there's 2 slides here. I'll show you both from low power, and then someone can tell me about them. Here's the next slide. Oh, there we go. Okay.
So it's a pretty large, I don't know if it's like a incisional or deep shave, but we're looking at a pretty densely, an area with like a lot of dense sebaceous glands. Some of them look a little more hypertrophic or a little enlarged. There's a background of sclerosis as well here, kind of thickened epidermis than I would expect for dermis for the nose. Overall, there is in various different areas I'm seeing more perifollicular and perisebaceous inflammation that looks more lymphocytic at low power.
Good.
And
what about this?
Oh yeah. Okay, so we also have some like early granulomas appearing
Good.
as well.
And then
cells. In other views, I was seeing plasma cells.
Yeah, good. There are. Here's some giant cells, some lymphs, and there are some plasma cells. It's sometimes hard to get them to show up, but there's a few plasma cells scattered in there. And then let me show you the next slide to give you some different views. Here, a lot more expanded sclerotic collagen, as you nicely picked up even in the last slide. Very good. And probably some plasma cells right here. See, plasma cells look big from low power because they've got a lot of cytoplasm. So if you see an infiltrate that looks kind of darker and bigger than lymphocytes, probably gonna be plasma cells. That's like my clue. They always catch my eye. These are all plasma cells. And then the last thing is over here. What's going on here? Here's lower, and then here's higher.
Maybe there was like a foreign body reaction going on towards, just like a ruptured follicle.
Good. Yeah, this is basically the pattern you see in ruptured folliculitis or ruptured cysts. Bunch of neutrophils filling up the lumen, necrotic debris, maybe some bacteria, plus minus. Sometimes it's hard to tell it apart from debris. And then all these pink round cells, those are detached acantholytic keratinocytes, which can happen when you've got some, skin, like some staph growing on the skin surface. You can see it sometimes in secondary impetiginization, where you begin to get some falling apart of keratinocytes. I think that's what's going on here. That's not a characteristic finding of this entity. It's just an incidental thing. But the neutrophils in this cystic space you can see in this entity. So how do you put all of this together? There's a bunch of different stuff going on. What do you think is happening here?
I was calling this Rhinophyma.
Well done. I was going to say, this is kind of hard because A, it's not a tumor, and B, it's something that I don't feel gets talked about or even seen that often, because it's often, is not, it's recognized clinically and not biopsied. So you either see it as an incidental finding in the background of something else. I've unfortunately seen a couple cases of angiosarcoma growing in Rhinophyma, and clinically it was hard to pick up on because their nose was already multinodular and reddish and inflamed, which is really sad and terrible. I've seen some cases of that. And other tumors, I've seen squamous cell carcinoma kind of hidden in the background of Rhinophyma, really bad, aggressive ones, unfortunately. But the times that I've gotten to see it is like this. This is actually from a time where they're doing the planing procedure, right? To remove and shave off the excess tissue and overgrowth and restructure and resculpt the nose, because it's more than just, as you guys well know, but for anyone watching online, this is extra tissue from the nose. I mean, this is about as much normal tissue. A normal nose, if you took a whole slice off of it, would have about this much tissue. So if you don't know how serious, not just cosmetically, but comfort and morbidity wise, Rhinophyma, when it's severe, can really be morbid for the patient and incredibly disfiguring, that their nose swells to multiple times the size of normal. It can obstruct their airflow through the nasal openings. It can be really problematic and inflamed. I don't know if it's painful, but I imagine it must be, because it gets all of these little pustules and ruptured, inflamed cystic structures in it. And so I imagine it must be painful and uncomfortable. So sometimes, oftentimes I see this done by either plastic surgeons or ENTs, although I think sometimes derms do it too, depending on their practice setting, but where this can be planed off and removed. And that's what this section was. And again, you can see cautery down here. There's cautery or electrosurgery artifact, the streamy, stretched out keratinocyte nuclei, and this burning and smudging of the collagen. See how the collagen gets more lavender or purple kind of color compared to the bright pink it should be? That means it's been burned by electricity. So in any case, this is Rhinophyma, beautifully done. And all of these different features in varying proportions can be seen in Rhinophyma. The way I kind of conceptually think of it is that it's kind of a follicular occlusion process where you get sebaceous hyperplasia and dilated cystic change to the hair follicles. Then they can have, and this is probably on a spectrum with or in some way related to rosacea, right? So you often have the rosacea findings of sebaceous hyperplasia with perifollicular lymphoplasmacytic infiltrate. But you begin to get inflammation inside these follicles, sometimes neutrophilic. The follicles and cystic spaces rupture open, which incites a granulomatous foreign body reaction to the keratin. And then you get subsequent scarring of the dermis, which gets more and more scarred down and sclerotic over time, which blocks down more of those hair follicles, which makes them cystic, which makes them rupture. Kind of the similar kind of process as you see like in acne keloidalis nuchae. I think it is much more complicated probably than that, but that is at a simple level the way I conceptually imagine how this process happens and progresses over time. And you can see this is scar, right? Dense scarred dermis. This is never going to return to normal. Once dermis gets so sclerotic, the scar may change and remodel over time, but you're never going to get back to normal, pristine dermis, right? So removing it is the way to kind of make it go back to a more normal shape after they resculpt the nose. And this is also a really perfect example of sebaceous hyperplasia throughout this specimen. And our little friend, the Demodex mite. This is Demodex brevis, the species that lives down in the sebaceous ducts, way down in the lobules. And then Demodex follicularum is the one that tends to live up in the infundibulum of the hair follicle. So try that out on your friends at your next cocktail party and see how impressed they are. This may explain a lot about my social life, but oh, look, there's another Demodex. Look, I mean, they're just wanting to eat some sebum. They're not trying to cause a problem. As you know, some people do seem to have some sort of hypersensitivity or allergic response to them, and there's debate over what role they play in causing or exacerbating rosacea, at least in a subset of patients. But overall, although people online like to post on my videos and tell me that they invade your body and cause all sorts of terrible problems, overall, Demodex do not invade. If they get into the dermis, they will die. They can only live in the openings here of the sebaceous duct and the follicle where they munch on this fatty sebaceous secretion and don't usually cause any problems, again, except with those exceptions of people who have like demodicosis and a hypersensitivity kind of response to them. Okay, so that is a really good example of the range of features that you can see in Rhinophyma. And don't forget to look around carefully in these specimens to make sure that there's no coexisting tumor that happens to be growing there, hiding clinically, not recognized because it's hiding in the background of a multinodular, large, firm, reddish, erythematous, nose in an older adult who probably has lots of skin abnormalities if they are sun damaged. So just keep that in mind, that you can have more than one thing on the slide. Any questions? Okay, and that Rhinophyma with Angiosarc case, I actually have that in process to be scanned eventually, and we'll eventually be posting that online and releasing it as a really good warning of the dangers of that potentially happening. Okay, case 8. We're almost there, guys. 50-year-old woman with a large pendulous masses of the bilateral thighs, the body mass index BMI 65, which is very, very high. Okay, so we've got 3 slides here. Here's number 1. Here's number 2. Here's number 3. Okay. Any takers? Who wants to put all this together for me? That's a crack in the class, by the way.
Give it a shot.
Okay.
So, I think, you see a lot of this edema between the collagen fibers.
Oh, I love that you picked up on that. Yes, good. Lots of white space. Good.
You sort of go in as sort of more of these sort of spindle type appearing cells.
Mm-hmm.
And then on the other slide with the adipose tissue, I thought we sort of saw some fibrous bands from intersecting some of the fat.
Yeah, here's a big expanded fibrous band right here. I wish I had a bigger piece to show you how it, there. You got a little taste of it here that it's intersecting between the fat. If you get a big enough piece, you can see, I guess we have some on this. There we go. Expanded fibrous band intersecting fat. Good.
I was thinking this was massive localized lymphedema.
Oh, well done, sir. Yes. This is massive localized lymphedema, which is really important to know about because it can be so large that it forms a tumor-like mass clinically, and the vast majority of it occurs in patients with morbid obesity. And because they have a really extreme lymphedema that compounds on itself and scars down, and it's chronic lymphedema that then becomes kind of sagging and hangs down and forms mass-like lesions that continue to enlarge over time as they get more edematous and more scarred down, okay? And there are other times where you can see it like in the scrotum and some other settings, but the times I've seen it by far the most are in patients with morbid obesity, okay? Now, I'm going to show you the clinical photos, which are pretty dramatic. So here you can see the skin of the thighs is really in multiple folds hanging down, and there's also a large pannus here hanging down, and then you can see from this view here that you can see how they form like a pedunculated mass-like lesion that hangs down from the inner thigh on both sides. These are often bilateral, and that's an important clue to recognize that even though this looks mass-like and tumor-like, it's probably lymphedema. And here's a different view from behind where you can see the one side better. So this obviously, you can imagine, is a terribly morbid problem for the patient who has this kind of obesity, and that obesity like this is a really serious problem and not an easy solvable solution, because even with weight loss, people, once they develop this degree of lymphedema, just like we were looking in that Rhinophyma case and the dermis gets scarred, the dermis in chronic lymphedema, even without massive localized lymphedema, the dermis in chronic lymphedema becomes scarred down, and it basically can never fully return to normal, even with weight loss or things done to try to improve the lymphedema, which is really unfortunate. Lymphedema is a terribly problematic, morbid condition for people, whether it's because of obesity, radiation, lymph node dissection, or other. It can be really morbid and painful. And also, people with chronic lymphedema over many years, they can have a risk of developing angiosarcoma secondary to the lymphedema. So let's go back here and look at these slides now that we've seen the clinical. So this form of lymphedema here, this actually has, I love that you picked up that there's extra white space in the dermis. Sometimes edema is very subtle. Here, there's white space, but there's also something else. The dermis is scarred. This is way more dense, more packed together dense collagen rather than the nice divided, reticular dermal collagen, which would look like bundles like this. Here we have packed together sheets of collagen with an increased number of enlarged kind of hyperchromatic fibroblasts and myofibroblasts in the middle. So we have both scar from the chronicity of it plus the white space of the edema. It's still got edema fluid in there, but the dermis is so unhappy about it that it's begun to scar in between the edema. So this combination of sclerotic collagen with edema is really characteristic. If I see that on the lower leg, that screams chronic lymphedema to me. The other thing that tells me lymphedema, because these are this is again not a tumor, so these are subtle things, non-tumoral reactive processes, often trick people because they're not things that are commonly seen or commonly taught about. So I think it's important to know. We had it, where was it? Oh yeah, there. The other thing is these are lymphatics. Normal lymphatics are little round spaces. These are dilated and kind of geographic, spiky, angulated edges, branching out in multiple directions. This is because of lymphatic stasis. Backflow pressure on the lymphatics makes these lymphatics dilate and kind of get ectatic and irregular in shape over time. So I feel like when I see significant chronic lymphedema, almost always you can find some lymphatic channels that are dilated like that, plus the edema, plus the scar, and as in any sort of chronic reactive thing that affects the dermis, like chronic arterial insufficiency, chronic lymphedema, you begin to get an increased number of fibroblasts compared to normal dermis. So if you're not sure, go compare this to dermis on a normal slide, because at first glance you're like, it's pink, it's dermis. And it takes a while to recognize the subtlety of the cellularity of the dermis and the collagen pattern compared to normal. But when you have it back to back, we don't have any normal here. But if you get a normal piece and compare, you'll see just how abnormal the collagen is in this. So this is all chronic lymphedema. And this same kind of pattern of fibrosis and edema often expands down into the subcutis. Oh, look, there's another dilated lymphatic. See? You can even probably see a touch of valve right there, probably. Sometimes you can really nicely see valves on lymphatics. And then it expands down. We'll come back and talk about the epidermis in a minute. Don't let me forget. Okay, and then what it does is in the subcutis, normally, a normal subcutis has lobules of fat with a very thin fibrous septa in between. But these septa expand and get fibrotic, sclerotic, scarred, plus edema, plus increased spindle cells in them. And the problem with this is that clinically, if they submit this as a large mass on the thigh in the soft tissue, and you get fat that you see mature fat, mature adipocytes, plus fibrous bands, plus some slightly enlarged spindle cells, you might start thinking about well-differentiated liposarcoma, which we call by the name, the alternative name of atypical lipomatous tumor. That's the proper name for well-diff liposarcoma when it occurs in the extremities or the superficial soft tissue. We call it well-diff liposarcoma when it's in the retroperitoneum, and atypical lipomatous tumor, even though that sounds like a descriptive made-up name, that's actually the proper name for it when it's in superficial soft tissue or in the extremities, because it behaves so much better there. But anyway, it can have overlap. Classic well-diff liposarc ALT will have hyperchromatic pleomorphic cells, but you can have very subtle cases that have very little atypia and look a lot like a lipoma with some fibrous bands. So I've seen cases where people sent these in a consult thinking they were liposarcoma, and they were all just reactive fat change from chronic lymphedema. So it's actually a very important distinction to make, because you're talking about a big surgery and labeling someone with a cancer diagnosis or a kind of like cancer diagnosis. So all of this is reactive fat change. As fat gets reactive, the vessels in it begin to get more prominent, especially when you get fat atrophy. So you can begin to see more vascularity than you do in normal fats. You can get little pockets of fat necrosis, lymphocytes and histiocytes. All of that reactive stuff can happen, which makes the fat look even more abnormal and cellular. All this is benign and reactive here. See, look how vascular this is. This is because this area probably got a little bit of atrophy, and so the normal vascular network that exists in all adipose tissue in our body to allow lipid to exchange in and out of the fat cells, they come closer together as the adipocytes get smaller and kind of shrunk down, and you begin to see more of the vessels, and it looks scary, and you're like, ooh, are those like chicken wire vessels of myxoid liposarcoma? Sometimes people can confuse it with that if you get some kind of atrophic changes. So that's just reactive. And those vessels are not the vessels of angiolipoma, just in case you're wondering. Those vessels are little clustered capillaries with thrombi in them, and I've got some videos about that you can check out. So I know it's a lot to take in, and I'm trying to cover it all real fast. Here, see? Oh, and then look, on this scan, those look like hyperchromatic cells. If I recall correctly, those were actually hemosiderin-laden histiocytes that just didn't quite scan and focus on the slide, because there probably been a little bit of hemorrhage into the tissue over time. I think there's a bit more in here. The other thing here that's going on in this patient is there's some fine calcifications. A little hard to appreciate, but we have some fine calcs here that are probably calcified elastic fibers. And, was it the last piece of tissue? Also some calcified vessels. Now, you can see calcified vessels as a reactive change, particularly in older adults or people with hypertension, called Monkeyberg's arteriosclerosis. You can also see calcified fibers as a non-specific finding. I particularly see it in the legs of older adults or people with bad vascular flow. But the other thing, especially in a patient that probably has type 2 diabetes, you have to wonder about their renal function and if potentially this could be some of the precursor calcifications that's maybe due to secondary hyperparathyroidism, chronic renal failure, and maybe incipient calciphylaxis. Clearly, this is clinically not calciphylaxis here, but I sometimes see changes like this in renal failure patients, and I always want them to watch the patient closely because I worry that the reason they may be depositing extra calcium is that they've got a parathyroid abnormality driven by their renal failure, and that some of these cases I suspect will go on to progress to actual occlusion of vessels and calciphylaxis. So when I see this in the setting of a renal failure patient, I do mention it and then say I don't see acute ischemia or clinical features of calciphylaxis, but these changes may be calcification that are related to the renal failure and they need to be watched closely. So just an FYI there. And I've got other videos about calciphylaxis that you can look at if you're curious. So that's a lot of stuff to cover, but it's a really complex thing, and I'm kind of, if you can't tell, a little fascinated. Now, the last thing about it, and then I'm going to show you a couple other clinical pictures. What about the epidermis? The epidermis is warty. It's got prominent papillomatosis with dramatic hyperkeratosis, right? Looks almost like a verruca or a seborrheic keratosis. So does anyone know what name we call this when we have a type of chronic lymphedema that gets warty reactive epidermal change? Some people even argued there might actually be some HPV-driven verruca type stuff growing in here, although I'm not sure if that's fully proven. I suspect it's mostly reactive, but what is the fancy Latin name that we can give to this?
Elephantiasis, nostrils varicosa.
Yes, elephantiasis, and I think the other person was probably going to say the same thing. Elephantiasis nostrus verrucosa. Everything's got to have fancy Latin names in derm and dermpath, right? So I've got some pictures. Now this patient, I showed you the clinical photo. Even though focal areas had that kind of verrucous change, overall, she does have some degree of kind of elephantiasis, arguably because of the large expansion of the legs and the tissue around them with lymphedema. But overall, I don't appreciate much verrucous change here. There may be some focal areas that have some verrucous change, but overall not much. But I've got some other examples to show you. This is a form of chronic lymphedema that causes massive expansion of the leg tissue and a verrucous type of epidermal change. I am still not fully clear why some patients get this dramatic verrucous change and others do not, and I'm not sure if it's fully understood, okay? So here's some pictures from not this patient but other patients. Here's an example of the kind of cobblestoning of the skin that you can see, whereas the skin begins to bulge up and make multiple nodular projections. Here's another one where you can see large, kind of almost cerebriform looking nodules. This is actually at the amputation stump at the end of the thigh. I've edited this picture to take out some potentially identifying background features to make sure that no one could possibly identify it, but that's just what's going on here. This patient was wheelchair bound and is holding the amputation stump from their thigh, and you can see the large kind of nodular lesions, in addition this kind of pebbly cobblestoned background that's more like the verrucous kind of look. There's another view of the same thing. And here's the most dramatic example I've seen, and this unfortunately was from an amputation specimen, where you can see how this corresponds perfectly with what I showed you in the slide of multiple papillomatous projections with hyperkeratosis on top of them. This was from, I can't remember if this was a double amputation, or I think it must have, maybe there were two different patients actually, now that I think it. This one I for some reason don't have the low power, because there are toes here, and even the toes are massively expanded by lymphedema. And this, I think, was a different patient where we had a lower leg amputation or foot amputation, and all of the digits are missing. But you can see, again, really dramatic example. And there's another look at it. And another look. And then finally, the cut surface. And here you can see the bone. We've got tibia and fibula. And then the fatty tissue, the muscle has been largely replaced. The fat has expansion and white fibrous areas. You can see that corresponds to those fibrous bands intersecting between the trapped lobules of fat. The dermis is extensively fibrotic and scarred. You can see the papillomatosis. I know this is a bloody, kind of bloody and disturbing picture to look at, but I think it really highlights perfectly what is happening here. And you can see, look at how much fluid is pooling up here from all of that edema fluid. So this is a great example that corresponds to what we're seeing happening microscopically in Elephantiasis nostris verrucosa. So back to the slide here. So I just showed the residents. If you're watching this on YouTube, I just showed some clinical photos. I think they're a little too graphic for YouTube, but I will link to them on a different website down below. So if you want to see those, they are pretty dramatic. If you have if you're sensitive about that, don't look at them. But otherwise, just so you know, you've been warned. But I think that they're probably YouTube will not approve them. But I do have another location where I can host them from. So Elephantiasis nostris verrucosa is this warty change in the surface that comes with some cases of chronic lymphedema. And the thing I wondered about for a long time is, what does it mean? Elephantiasis, I know, means enlargement and kind of expansion of the leg. Verrucosa, I can figure out, verrucous, right? But nostris, well, after finally a lot of digging, I found an old article from the early 1900s that explains that the idea of this at the time was that elephantiasis was something seen in tropical regions. Tropical elephantiasis, either filarial, or some people get non-filarial forms that are not parasitic and that are driven by podoconiosis, I think is the word, when people have barefoot on volcanic soils and they get that silt in and it damages and scars the lymphatics and they get elephantiasis from that. That's not due to a filarial worm. But then this doctor noticed that there were some patients that had elephantiasis in Europe. And so nostris means ours. It's like, this is our form of elephantiasis, ours meaning in the European continent, as opposed to the type we see in the tropics. Now, whether that's totally socially appropriate nowadays, I don't know, but that is the history and origin of that term, that this is something that happens in the non-tropical setting and through a different cause, a different mechanism than the types of elephantiasis that are more often seen in the tropical setting. So in case you ever wondered what the nostris meant, that's what it comes from. And I have a paper that I found about that, and I'll link to that down below in the video description as well. Okay. That is more than you ever wanted to know about chronic lymphedema, but it's a really important topic and is often overlooked. I often see people miss this, especially when it's more subtle. So do you have any questions about this? And then we'll go on to the last case. Okay. I mean, what else is there to talk about it, right? We've covered it all. All right. Let's do case 9. This is a 25-year-old woman with a nodule on the back. Again, my apologies. This is the best case I have to show this, and I didn't have it scanned yet. I'm working on that, but we can see here. So here's my first question was, what is this? What is happening in this photo, and what does it mean? And then I'll show you the rest of the pictures, and you can tell me what tumor. I guess I'll go ahead and click through that, and someone can volunteer. I'll come back. I'll just let you see them all. Okay, great.
So that first photo that you showed looked like cells entrapping a nerve.
Good. This is a nerve, and these are cells completely wrapped around that nerve, hugging the whole thing, a donut around the nerve. Good. Now I'll click through the rest of them, and then I'll come back and let you describe. Here's another little nerve, and another view of it, and again, more nerves, and another nerve. Okay, now, what are we dealing with here, and what is the significance of that nerve involvement?
So there is an abundance of polygonal, plump, eosinophilic cells that have granular cytoplasm. They're in nests and cords, and obviously kind of surrounding some of those peripheral nerves. It has irregular borders, and it's kind of infiltrated. Even the nests are not encapsulated. So it looks like something maybe of neural sheath origin.
Good. Yeah, here's that. Here's that. You can kind of see from low power that infiltration you described is not well circumscribed or encapsulated, right? It trickles out between the collagen, and there's lots of collagen trapped up in the midst. It's kind of just trickling throughout the dermis. Good. I love that you described it that way. I think that's a very important clue. Okay.
So I imagine S100 would probably be very positive.
Yes, it would. S100 would be very positive.
Because I think it's a granular cell tumor.
Excellent job. Great description. And yes, this is a beautiful, perfect example of a granular cell tumor with the nests and trabeculae of kind of a syncytial arrangement of these epithelioid or polygonal cells with granular cytoplasm that's pale pinkish gray. And they're kind of trickling between the background collagen. I find that they almost always do that. They don't make like a nice circumscribed nodule. They just kind of weave in between the collagen and around things and into the fat. I've even seen them go into the muscle, and that pattern of growth does not imply aggressive behavior. That's just the way they grow. Now, what about the nerve surrounding? What do I need to, what kind of comment do I need to make about that, or does it change what we call this?
And it's actually not something to worry about.
Very good. Yes, this is something that is not something to worry about. And I first learned about this actually once I was in practice after fellowship. Maybe I was told in fellowship and just forgot, but Jennifer McNiff gave a talk. She was a past president of ASDP, and she's a wonderful dermpath at Yale and dermatologist. And she gave a great talk at ASDP long ago when I was early in my career, and talked about how perineurial involvement, I don't call it invasion because it doesn't mean the same thing here, perineurial involvement by granular cell tumor is not only allowable, it's actually present in the majority of cases. And in their study, I think they found it in like 88% or something, close to 90% of cases. So if you start looking for it, you will actually find it. It is there. Perineurial involvement in granular cell tumor is okay, is benign, and is actually very common in this entity. So I'll put a link to a paper describing this down below. So in general, when I see this, I do not mention it at all. In the past, I don't take consults anymore because it was getting too busy for me to handle. But in the past, I used to take consults, and when people would send it in and say, oh, there's nerve involvement, then I would comment on it. Yes, we see that in granular cell tumor, and it's a totally fine, benign feature. And when you think about it, granular cell tumor, even though they look very different from other nerve sheath tumors because of their abundant granular cytoplasm, they are neural tumors. So we see neurofibromas involving nerve. We see schwannomas involving nerve. Why should granular cell tumor be any different, right? It makes perfect sense that it would involve a nerve. Just looks so different from nerve, and kind of reminds us the way carcinomas or melanomas grow around the nerve, I think. So it really activates that part of our brain that thinks, oh, perineurial invasion, because it looks so distinctly different from the nerve itself. And so usually, I mean, these are H&E diagnoses, although there are some rare other form of granular cell tumor that's non-neural. And it's a somewhat controversial entity that we can talk about a different day. But in any case, if you want, you can stain them. They're going to be S100 and SOX10 positive, like any nerve sheath thing would be. And they usually will also express CD68, although I never do this. It's not needed. PAS could also be used because it'll highlight that granular cytoplasm, because these cells are granular because why? What is filling up their cytoplasm and making it look granular? Yeah, these are phagolysosomes, and CD68 is not a histiocyte marker. It is actually a phagolysosome marker. So any cell that has a lot of phagolysosomes in it are going to be positive for CD68. It is not a specific marker of histiocytes. It's sensitive because histiocytes usually have phagolysosomes, right? So, so in any case, yes, co-expression of S100 and CD68 for testing purposes. I think PAS will also stain the granules. In real life, I usually diagnose them on H&E, or I might do an S100, but honestly, when they look perfect like this, I usually just diagnose them on H&E myself. So in any case, there are rare examples of malignant granular cell tumor I've only seen in study sets. And then there are some that have some atypical features that still usually behave indolently. And I'll put a link to a paper about that down below, about the features that help you decide when a granular cell tumor is atypical. Random scattered nuclear pleomorphism, totally fine in these, just like it's totally fine in neurofibroma or schwannoma. Random so-called degenerative nucleotypia, not a problem at all. If I start seeing spindling, real extensive, large nucleoli, mitotic activity, then I start worrying, and I always go pull that paper out and read about it to make sure that I've got the criteria right for deciding how much atypia is too much. But random atypia, don't worry. Perineurial involvement, don't worry. Sometimes these can be multifocal. You can have patients with multiple granular cell tumors, which always seems a little scary, but it's also fine to have in these patients. And was one last thing. Oh yeah, this case doesn't show it, but classically these are taught as inducing a lot of mucosal, if they arise in the tongue, which is a common site, or epidermal hyperplasia that can mimic squamous cell carcinoma, and it can. I've seen cases where it's very dramatic, and it sure looks for the world like an invasive well-diff squamous cell carcinoma, all reactive. So the general rule, especially for pathologists looking at something on the tongue, if you think it's a well-diff cancer, look in the submucosal connective tissue to make sure you're not missing granular cell tumor there. I've also seen ones that had verrucous-looking change on the surface. And just make sure you check down here in the collagen. If you find granular cells, stop. Don't call it cancer. It's probably just reactive change from the granular cell tumor. But you don't have to have that change. I've seen plenty of granular cell tumors just like this, where there's a little hyperplasia, but nothing that looks like pseudoepitheliomatous or that would be confused with squamous cell carcinoma. And the final thing is that people like to talk about these things called pustulovoid bodies of Lesion, and they're like little little blobs of granular cytoplasm that stand out. Let me see if I got one in here. I can't remember. Like right here. See, there are these little tiny little clustered aggregates of granules in the cytoplasm that stand out with a little space around them. I don't really feel like you need them to make the diagnosis, but people talk about them, so now you know. Now you've seen the Pustulovoid body. Here's another one right there. Okay, that's granular cell tumor with benign perineurial involvement. Okay, any questions about that? Well, guys, I only went a half an hour over time. I hope you'll forgive me, and hopefully it was worth your while. And if you have any questions, always you can message me or contact me online. And anyone watching this online, thank you for watching. I hope you have a great day, and check down below for links to more content related to this video. Thank you.